speaking of positioning, how do you usually position your clients as in terms of like in the bed?
So, if it's a severe burn, I mean, that's mostly what we're looking at in regards to positioning, and the majority of the positioning needs are for patients that are in the ICU. A lot of the times they may or may not be vent dependent, but a lot of the times a severe burn comes in and they are in a medically induced coma, so that they can, assist with keeping them with limited activity, so that they can go ahead and really focus their efforts, body-wise on healing. So a lot of the times what we're looking for positioning in bed is major areas of concern for scarring and for limited range of motion are shoulders. So we want to, at one point in time we were doing more of a out in 90 degrees of abduction, but we found that sometimes we were getting some nerve impingement in the shoulder area. So now we're going ahead and we're doing more of, like, we like to refer to it as scaption here at the hospital. It's a combination between abduction and forward elevation. So we put them on, we actually got these a couple of years ago, and this is a blue foam wedge that we use very often in a patient's hospital bed, and you just position the arm as so. So it's it's assisting with edema, and it's also keeping their shoulder, as you can see, in a position where you're getting a good stretch at that axilla. Okay.
And do they usually tolerate that well?
When they're in the medically induced coma, they do.
Yeah.
But as they're trying to get them off of the paralytics and, get them more off of their vent, it does become more of a challenge, because they become more agitated, or, there are times where it is definitely a struggle. But there are times where we have very compliant patients that are really willing to do whatever they can to go ahead and try and get the best outcome. Then the other thing that we do is we also use, this is actually a prefabricated splint, but I just didn't have at the time one that I have actually fabricated, so I went ahead and I just got this just for the purpose of having something to show you guys. But basically what we're looking for in the hands is, one of the things that we'll do is we have to go in, and when we do our initial eval, we need to see how the edema and how the wound is affecting their range of motion, whether passive or active. We need to, here at the hospital, we go ahead and say, if we can't get somebody to 70 degrees of MP flexion, whether active or passive, then we go ahead and we say that's an indication for splinting.
Arista, you have a phone call. Arista.
We'll go ahead at that point in time and we'll bring to the bedside, splinting pan and whatnot. It's a pretty involved procedure, especially if somebody's in an intensive care unit, but it's really beneficial, especially if they're in a medically induced coma, because they need to have a good positioning to get